So I got, yeah, I have turn on caption. Yeah, say apa? Kak Dayah give me some instruction how to record, but I cannot see that. Tadi lah. Yeah. So who's going to record? Any of you? So you got a way to record this session, eh?
Yes.
Okay, but that's fine. I'll let Kak Dayah know about that. Yeah. Is it Aiman yang record ni?
Aiman.
Aiman record eh? So okay, eh. Okay. Yeah. Okay. Fine. So so I give it to case scenario. So we're going to conduct the scenario like you doing long case presentations. But so one of you will lead the case. I've done this case with group 1 this morning. It took me 3 hours to finish those 2 cases with them. So we started at 10 o'clock. We finished about 1:15. So I'm hoping that I'm not going to go through that 3 hours with you guys. So as long as we got all participation with all of you, so I think we can go through this quite quickly. Okay, I'm sure that you guys want to go to ziarah raya, visit raya, eat more rendang and more lemang after this end. So what we do is, so one student will lead the case discussion. Basically try to go through history bits, what question you want to ask, and like you're doing the long case punya presentation. Okay, and then I will ask you for the question, and then all of you can chip in, can participate in terms of asking, giving answers and so on. If you've got any question, you can just interrupt the discussion. I'm not going for formal session. You're going for very informal. So that's why I'm not wearing my makeup here, because it's a very informal session. Okay, fine. So so yep. Who's going to lead for the case 1?
Me, Doctor.
Okay, fine. All right. Let Africa bombard it with all the information.
So I will present. Where is it?
Okay.
Can you guys see my presentation?
Yes, we can.
Is it a full slide?
Yes, full slide.
Oh, sorry, let me adjust my fan.
Ada 2 no Afrika Same people ke ataupun different people?
Kalau dia present memang akan keluar 2.
I see.
But actually there are 2 different Afrika.
Different Okay. Okay.
Oh, Afika punya.
Oh, ada dua lah Afiqah, betul lah.
So for case 1, Farah, 6-year-old girl who present to A&E department where her mother states that Farah's urine has turned red. She has brought a jar of urine which contains what appears to be reddish brown urine. She has no dysuria, frequency or abdominal pain, and there is no history of trauma. She is otherwise well, and she and the rest of the family have recently had colds. There have been no nose bleeds or abdominal bruising. She has had no problems with her joints. She had a urinary tract infection at the age of 4 years, but following a normal renal ultrasound, she was discharged from clinic, and she is on no medication. There is no family history of renal problems, but her grandmother has hypertension. Okay. So from this case scenario, so we have received complaint 6-year-old girl which complain of urine turn red. Anybody has any idea about this chief complaint?
It was hematuria.
Hematuria.
It was a gross hematuria.
So we can say that she has a gross hematuria, and then how can we confirm that it is true hematuria or other causes that just turn the urine to be red?
So we can get from the utilization, such as food, from the food.
Pardon, Afika, I cannot hear you.
We can get from the utilization,
History taking, such as
such as any food that can cause red urine, such as beetroot,
some more. Is there any more
or drugs.
drugs? Okay.
Sorry, can you repeat that? I couldn't hear her clearly.
Afika said that we should rule out if there is any history of taking food that turn the urine color to be red, such as beetroot, or any drugs that can turn the urine to be red. Okay, so we have some glance of history of presenting illness, which is the mother brought a jar of urine which was reddish brown in color. So from this information, can we have any idea?
The brown color of urine may indicate that the origin was from glomerular, because usually glomerular hematuria has a brown color urine.
Yes, I agree with Nadira. So from the color of the urine, we can differentiate the origin of the bleeding. So if it is extraglomerular bleeding, how the color would be?
More reddish in color.
Also presence of blood clot together with the
Come again?
if the causes is glomerular, so usually it will be frank red and also presence of blood clot.
Yes. And then is there any history from the that further history question that you want to ask about the urine?
Yes, I would like to ask associated symptom such as signs of low urinary tract symptom. You can use the pneumonia, such as the patient may present it with fine dish, frequency, urgency, bacteria, dysuria, incontinence, training, post-training, and also hematuria.
What is the last one that you mentioned? Can you repeat?
Hematuria, fine dish.
Hematuria. Is it not hesitating?
I hesitate.
Hesitancy.
Um,
Okay.
okay. And then there is also information that Faraz and her family also had recent history of cold. So from this piece of information, what can we get?
Maybe we could explore more regarding the cold, whether they have any associated symptom with sore throat or not, because we can consider post-streptococcal infection.
Can you come again? Your voice is too slow.
Maybe we could explore more regarding the cold. Need to know the associated symptom with the cold, such as sore throat, which usually the presentation for post-streptococcal infection.
Okay. Yes, I agree with you. So, recent history of cold may indicate any post-infectious glomerular nephritis.
Okay.
Pardon, doctor?
No, I'm just saying okay.
Okay, so we are given some relevant negatives such as no dysuria, frequency, or abdominal pain. Asfa want to answer what is the significance of this sentence? Asfa?
Okay, maybe that's just want to rule out for any lower urinary tract symptom. So maybe to rule out for any UTI, something like that.
Yes, I agree with you. And how about the abdominal pain? Is there anything that you want to comment?
Abdominal pain, I'm pretty sure abdominal, just want to rule out. Abdominal is like very general, like the localization. So want to like for any loin pain or any suprapubic pain. Like for suprapubic pain, it can be like cystitis, can cause hematuria. Or loin pain can cause by the stones,
Okay.
pyelonephritis.
So nephrolithiasis. And then there is no history of trauma. Is there any hematuria that caused from trauma? And then there is no nosebleed and abnormal breathing.
To rule out bleeding tendency,
Okay.
hematological problem.
Pardon, Nafika?
Hematological problem.
Okay. And how about the sentence of no problems with her joints?
To rule
We
out
need to exclude the multi-system. We need to exclude the multi-systemic disease such as SLE. And also, I think the history, we should inquire further if there is any rashes on her body to exclude if there is any evidence of HST.
Is it?
Yes. Rashes around the lower limbs and also buttocks area.
Okay.
Okay, for the past medical history. So she had urinary tract infection at 4 years old. And she was discharged because of the normal renal ultrasound. Is there any comment about
there was no structural abnormality,
no structure abnormality such as? Is there any complication that we expect from UTI?
adenonephrosis,
Hydronephrosis. Some more?
Maybe that is the
Who is talking?
Another reason question.
Maybe because it is the first presentation for this patient, so I think that's why the ultrasound might be normal.
Okay.
And for is there any complication of UTI that you rule out by doing ultrasound?
Renal scarring?
Come again?
Scar.
Renal scarring. One more?
The VUR.
Yeah, basically urethral reflux.
Okay, I just want to mention that by doing a renal ultrasound scan, you cannot rule out scarring. You cannot rule out a VUR. Okay, so ultrasound scan of the abdomen or ultrasound scan of the renal only looking at the shape of the kidneys, looking at the structural anomalies, like if there's hydronephrosis, you can see the hydronephrosis. You've seen the bladder. But if you're talking about renal scarring or VUR, you need to do further tests to rule out the scarring and also the VUR. Obviously, the scarring will lead to kidney atrophy, means that your kidneys can shrink. So you can measure the size of the kidney, but it does not seeing or ruling out renal scarring. For VUR, as the name suggests, VUR, which is vertical ureteric reflux, means that there is urine being reflux from the system, from the bladder to the ureter, means that you need to do dye testing, which is MCUG, which is micturition cystourography, to see the movement of the urine from the bladder to the ureter. So by doing the ultrasound scan, you cannot rule out VUR. Okay, so the ultrasound scan is mainly for if you're looking at the duplex kidneys, or you're looking at the polycystic kidney disease, you're looking at the hydronephrosis, you're looking at the possible inflammation of the bladders or inflammation of the renal parenchyma, then you can look by using renal ultrasound scan. But if you're talking about VUR and renal scarring, renal ultrasound is not useful. Okay.
Okay, can I ask question? Regarding the MCUG, is there any age limitation that we
Okay.
can?
So because if you do MCUG, okay, MCUG is basically you need to put the CVD, you need to put a catheter into the bladder, and then you need to inject a dye into the bladder and then you do the X-rays of the bladder to see the movement of the dye. So normally because you need to put a catheter, so normally you do it for age less than 2 years old, or if the child be able to comply with that procedure, you can do it at any age. But obviously, putting a catheters in the 4 years old is not it's not straightforward, because they won't be complying. So if that is the case, then you might need to do DMSA scan, or you might need to do other modulation to rule out to detect is there any VUR present in the kidneys. Okay, so basically for drug history, there's no medication. It's just on a medication. And obviously there is a family history of hypertension in the grandma, but nothing else to suggest any other renal problems. I don't know whether Africa want to go through the family history or hereditary renal family history. Ada ke?
Doctor, may I ask? regarding the family history, even though it was already stated that there is no family history of renal problem,
Yep.
can we still suspect for Alport syndrome?
I suppose Alport syndrome is autosomal dominant, isn't it? Yeah, Alport syndrome. It's autosomal dominant. So if there is any history of Alport syndrome in the family, then it should be noted. Parents should know there is some issue of Alport syndrome because it's autosomal dominant. So if the patient say, if the parents say there's no family history of renal condition, then you basically say there's no history of Alport syndrome. Okay? Because there's not many kidney inherited kidney disease that we know. Kalau ada pun you're talking about polycystic kidney disease. Talking about duplex kidney also can be inherited as well, and then there's autosomal recessive condition like RTA, renal tubular acidosis, that can be inherited as well. But most of the kidney disease are acquired kidney disease. The most important thing that you want to know is when you got UTI, you need to know what is the age when the patient had UTI first time. Okay. If the patient had UTI in the first 6 months of life, it's likely that the UTI due to congenital causes. Congenital causes means that it could be structural anomalies like VUR, PUJ, or congenital hydronephrosis. So it's very important to know. It is very important that if you got somebody less than 6 months old, like 2 months old, 3 months old, that have confirmed UTI, you always proceed with renal ultrasound scan, because it could be about 20 to 30% of them might have renal anomalies, renal tract anomalies, VUR, PUJ, or congenital hydronephrosis. So it's very important to know the age the first time they have the UTI. So if this one, Farah got UTI at the age of 4, that is probably acquired UTI, not really because of the congenital problems. Okay. Okay, so let's go back to the history. So this is a 6-year-old girl, came into the ED department with a history of blood colored urine, okay, red colored urine. Okay. So if I go back to asking Africa again, so when you hear the chief complaint, the presenting complaint about red colored urine, can you list down the possible differential diagnosis that you'll be thinking? If you don't want to answer the question, that's fine. You can pass the button to your colleague. You have Azfa, you have Ayman to ask the question. What it has
I would like to try that.
You can try.
So for hematuria, for causes of hematuria, we can divide it into glomerular causes and also non-glomerular causes. So for glomerular causes, it can be infectious glomerular nephritis.
Okay. Okay. It's okay. You don't need to be panic. If you start, that's okay. You can always as long as you keep your social distance very well, you can pass the question to your other colleague.
Okay, I pass it, doctor.
Okay. You need to pick the name to pass the question.
Fikriya?
Yes, me. Okay. I would like to divide the causes of hematuria into a few main category, which could be the infection causes, could be UTI, which is I would like to ask the urinary symptoms, could be upper or lower UTI. So if the upper UTI should be a complaint of abdominal pain or loin pain. So other causes could be stone, which is nephrolithiasis, The presentation also could be associated with other urinary symptoms, which is as mentioned by Dahlia Pandis. And then for the other causes of hematuria, I would like to rule out the iatrogenic causes or the benign causes of hematuria could be caused by the food intake, which is food dye, the beetroot, or the drug causes, which is usually causes by the rifampicin or levodopa. And then for the autoimmune causes or multi-systemic causes could be due to the SLE or HSP. And then the patient also could get hematuria due to the congenital or hereditary causes, which is autosomal polycystic kidney disease. ID causes. Patient also, that's why there's the history asking about the bleeding tendency. Patient also could have been hematuria due to the bleeding tendency, could be congenital causes or acquired, which is for the congenital, could be hereditary, could be the hemophilia. That's all for me.
Okay, so basically, the first thing is when you got any chief complaint, you need to list down all your possible differential diagnosis. Okay, once you got your differential diagnosis, then you know what question you want to ask, isn't it? So if you're talking about if you think about nephritis or infectious nephritis, then you want to know, is there any recent precedent illness? You want to know whether what color is the urine? Is it very dark color? Is it dark brown? Is it clot in the urine or not? So those are the questions that you want to ask parents, because by asking those questions, you can narrow down what is the possible working diagnosis later on when you finish your clock in. So that's why it's very important to know your differential diagnosis so that you can ask further questions. Okay, fine. The most commonest things when you heard about hematuria in a child will be UTI, isn't it?
Yes.
Okay, so that's the first commonest, the most common thing that you've been thinking about. So from the history, what are the questions you want to ask further to complete your question about UTI?
So for UTI, for this patient, I would like to ask further about the infective features like fever, because it hasn't mentioned about the fever, and then any other urinary symptom, but it's already mentioned about the dysuria and frequency, and any involvement of lethargy like poor feeding, which is signs of severe infection, and for infective features, mainly the infective features of the UTI.
Okay. So when you're talking about UTI, you're talking about in this case, we know that the patient has no dysuria, no abdominal pain, no frequency. You're also talking about possible suprapubic pain as well, if there is any suprapubic pain. Other UTI kind of question that you normally ask is there any fever with the child? So fever is a kind of like a common indicator to suggest an infection anyway. So you want to ask about fever in a child. Other question you can ask about UTI, is there any discharge? So PV discharge, or if kalau boy, then you ask about penile discharge, or sometimes you can ask about, is there any redness around the foreskin? So balanitis also could be part of the features for UTI. Okay. Then sometimes you can ask about loin pain. Pyelonephritis, and pyelonephritis can have loin pain. You can have loin pain with the pyelonephritis. With cystitis, you can have suprapubic pain. But if you got pyelonephrocystitis, then you got pyelonephritis plus cystitis, then you can have loin and suprapubic pain. Okay, or flank pain that normally we say. So these are the questions that you are going to ask. As your colleague says before, it's about reduced feeding. So sometimes in children, it's difficult to say to them whether you got any nausea or vomiting, because nausea is not something that a child knows how to complain. You know, if kalau macam budak yang umur dalam besar sikit, mungkin dalam 7 tahun, 8 tahun, maybe they know what is nausea, feeling lawyer kan. In a child at probably 4 or 5 years old, reduced feeding or lethargy probably the best way to indicate that the child might have nausea. Okay, vomiting is quite common to associated with UTI. So vomiting is just a simple one. Is there any vomiting in the history? So those are the quite common UTI question that you're asking patient or parents. Okay.
Can I ask? In a book, they said that we can also ask for offensive urine. What does it mean by offensive?
Oh yes, sorry, foul-smelling urine. Yeah, so foul-smelling urine also can be a part of the question in the UTI history. Yeah, cuma sometimes foul-smelling urine is not ask kakak what. Foul-smelling urine is a bit difficult because sometimes you know, kalau macam 6 years old ni, you should be able they normally go to the toilet themselves, they clean themselves you know, independently anyway. So sometimes foul-smelling urine is not really part in the history because parents don't really know if there is any foul-smelling urine. If the child is if the child is babies 2 to 3 years old who still wearing nappies, then they probably can tell you that the nappy is foul smelling, or the smell of the urine is slightly more strong than usual. Okay. If you're talking about PV discharge or the penile discharge, sometimes if the parents can describe to you what kind of discharge they have. Is it a whitish kind of cheesy looking, or yellowy greenish colors, white colors or not? So those are quite important as well if they got any discharge. Sometimes children can have bacterial vaginosis, which is not that common. More common in children is fungal candidiasis down below. So sometimes you can see parents describe the smell of the discharge like a fishy smell, fishy odor, and so on. So those are suggestive of possible fungal infection if there is any. Okay. My further question is, you know, obviously the recent history of colds is very suggestive of post-streptococcal glomerular nephritis, isn't it? But I just want to ask you for the question: why is it important to know whether there's any nosebleed or abdominal bruising? Oh, sorry, abdominal bruising. What kind of pathology that you are looking for?
Bleeding tendency, doctors. Which is,
Okay, so what kind of bleeding tendency that you expect in a child?
Hamish. HSP.
Is it ITP?
Yeah, doctor.
Okay.
Hemophilia.
So you're talking about if you're talking about bleeding tendency ataupun hematological condition, you're talking about hemophilia. Okay. Okay, what else?
I think that can cause thrombocytopenia, which is SLE could be one of the.
Okay, so
ITP.
thrombocytopenia, which is the most common one is ITP.
Yes. About hemolytic uremic syndrome.
So hemolytic uremic syndrome, man. Hemolytic uremic syndrome, which is you got the hemolysis of the red cells. So sometimes you see a patient that is quite pale, coming with probably lethargy as well. And sometimes the urine color is quite brownish red color as well. So hemolytic uremic syndrome can be possible in this case. But obviously, hemolytic uremic syndrome, you need to look into the full blood count and also the renal profile to diagnose that. But normally, hemolytic uremic syndrome tend to happen after acute gastroenteritis or E. coli E. coli 0157 infection that cause hemolytic uremic syndrome. Okay, so basically for the nosebleed and also abdominal bruising, you are talking about ITPs or hemophilia, because hemophilia can come with hematuria. Okay, the thing in this case is a girl, so hemophilia is slightly is basically unusual in hemophilia, because hemophilia is mainly X-linked recessive conditions. Okay, and then if we go through to negative relevance, like no problem with joints, no problem with abdominal pain, what kind of pathology that you are ruling out here?
HSP,
Probably autoimmune disease
ruling
Okay.
out
such
HSP.
as SLE.
Yeah.
A,
So it's mainly you're talking about autoimmune rheumatology conditions or vasculitis, isn't it? So SLEs and also HSP. So HSP and SLEs, both of them are vasculitis anyway. Especially SLEs you can have systemic SLEs ataupun systemic vasculitis that affecting all organs in the body. HSP it is vasculitis, but what is the 5 organs that normally involved in HSP? So anyone can mention to me what is the 5 organs that involved in HSP? Africa, you can take the lead, or you can pass the question to your colleague if you want.
can you answer that?
Mm-hmm.
So 5 systems that are commonly involved in HSP. First is skin, which presented with skin rash, which is the purpura itself, and then in the independent area. And the second one is arthralgia. This is joint involvement.
Mm-hmm.
The third one is GI involvement. Usually, patient will have colic abdominal pain,
Mm-hmm.
and then the fourth one is renal.
Okay.
Which is glomerular nephritis can be one and presented with hematuria. And the fifth one, it can periarticular edema. Is it
Mm-hmm. Which is joint.
joint also?
Mm-hmm.
But around the articulating surface area.
It's mainly joint. Okay. So you got skin, you got kidneys, you got abdomen, you got joints. So what is the fifth organ that is normally involved in HSP?
Intestine.
Trachea.
Lung.
Okay. Lung is very rare.
I read that uncommon involve intracranial hemorrhage.
Okay, so so the fifth one is CNS involvement, isn't it? Okay. So let us Asfar. So can you explain to me the pathogenesis of HSP that lead to skin, joint, and also renal involvement? Enggak ada, hello? Kita kena Google tu.
Hello? Okay. Sorry. So Hematuria pura, the pathogenesis may be due to the immune complexes that deposit into the organs, so that cause the inflammation.
And then so how that pathogenesis lead to skin purpura?
Skin pura.
Maybe because of the vasculitis, because
because of the
You kena repeat balik Faham, repeat balik. You want to try again? Hello?
Farhana, need to repeat your answer. We cannot hear you.
no. Can you hear me? Hello.
Okay.
So HSP, because of the immune complexes, they can cause vasculitis because of the IgA deposition.
Okay. And then what happened after that?
And then what? Sorry?
So it caused IgA deposition, lead to the vasculitis, and then vasculitis lead to lymphocyte infiltration.
Hemorrhage. Right, I know.
Okay. So basically, IgA deposition lead to vasculitis. What actually vasculitis?
Inflammation of the small blood vessels.
Okay, so inflammation. So the blood vessels become inflamed and they become swollen. When it becomes swollen, it becomes leaky. The permeability there increase. So that's why you got this leaking of red cells, of protein sometimes. But for the skin condition, sometimes you can feel the raised purpura when you feel the HSP. The raised purpura because of the deposition or leaking of the fluids and also a bit of protein onto the skin surface or underneath the skin, and plus with the RBC, the red cells also leaking from the vessels, and then it basically deposited underneath the skin. So that's why you can see the purpura or the bruising in. So those are the pathogenesis of HSP that lead to the purpura. Okay, so can you now explain how HSP lead to hematuria, proteinuria, and also the joint problem?
May I try?
Aiman can try.
Because sorry, I can't even hear my own voice here, so I'm sorry if it's not clear because it's raining here.
We can hear your voice. We just cannot see you. I think you probably eating some rendang and
Sorry,
lemang.
I
That's
don't
why.
have a camera.
Betul.
And because first because of the vasculitis, due
Mhm.
to the deposition of the leukocyte, and then it causes glomerular messenger proliferation and inflammation. And then it causes damage to the glomerulus, and then it become ischemic. Also ischemic, and then it causes all of the symptoms such as hematuria.
So which part of the glomerulus yang become ischemic?
Podocyte.
Okay.
Also tubulointerstitial structure.
Okay. Okay. Everybody agree? Or someone has someone has other version of explanation?
Agree.
Asfar want to try again.
No, I agree with Aiman.
Agree with Aiman. You agree with Aiman. Okay. Well, I kind of agree on the first bit where you mentioned about deposition, you mentioned about inflammation and so on. It's just that when it comes to the ischemia, I'm not so sure whether HSP really cause ischemia. We know that vasculitis, because all of these are process of vasculitis, so it's all about inflammation of the blood vessels anyway. So the blood vessels become inflamed, it proliferated, they become more porous, it increase the permeability of the blood vessels and also the basement membrane. Then you got the leaking of intravascular components, including the red cells, the protein, and sometimes the leukocyte also can come through the basement membrane as well. So that's why when you do some dig dip or the UFAM for patient who has HSP or sometimes glomerular nephritis, you can see the bloods in there, you can see the protein in there as well, and you can see the lymphocyte as well. But not all has lymphocyte, because lymphocyte is quite a big molecular size for the vasculitis. Okay, so that's those are kind of like, you know, explanation why the HSP involve 5 organs. It's vasculitis that happen anywhere in the body. Mainly it's affecting the skin, the joint, the kidneys, the abdomen, and also the CNS. CNS involvement in HSP is very, very rare. I've not seen any HSP cerebral vasculitis. I've not seen somebody who has HSP coming to me with raised intracranial pressures or intracranial bleeding or seizures. So it's a very rare occasion as part of the HSP complication. Okay, fine. Okay, let me see. So, in this case, I'm just going to share you my one slide here about examination finding. So I'm trying to see what I can share. Okay. Okay. Can you see?
Yes, doctor.
Okay. So basically, you examine the child. The child has no sign of pallor, so it means that there's no anemia. The child is apyrexia. The child has no skin rash. There's no bruising. The legs are normal. There's no edema. There's no abdominal signs or joint abnormalities. Okay, the blood pressure is 124/80, and there's no signs of there's no other sign. Mana kalau buat respiratory ke CVS examination, they're all normal. Okay, so back to Africa. So looking at the histories and then looking at the examinations, so can you make a conclusion from this, from the information that you are given?
Hello.
Hello.
So from the information, so there is no anemia, meaning there is I think this piece of equipment want to rule out HSP or HUS. And then she is apyrexia, so there's no evidence of fever, or maybe want to rule out any UTI. No skin rash or bruising. This statement want to rule out in there is no not HSP. And there's no edema of the legs. Yes.
So edema of the legs, so meaning that?
There is no evidence of nephrotic.
Okay.
And then no abdominal sign or joint abnormalities. This statement want to any this one the multisystemic disease such as SLE or HS.
HSP, okay.
HSP. And then the blood pressure is normal.
Is it normal?
Ada sign.
Is it normal or is it hypertensive? Can anyone else? So anyone else agree that this is normal BP for a 6-year-old?
I'm not sure doctor for 6-year-old.
You're not so sure. How do you know it's normal or not? What are you supposed to do when you have a BP measurement?
Chart for the percentile.
Okay, so you want to plot onto the BP chart centile, isn't it? Okay, so before you plot this BP reading onto the BP centile chart, you want to know the weight and the height of the child first. Okay, so once you know the height, then you know which centile that you can plot these numbers again. However, for the rule of thumb, normally if the child kalau lah BP measurement ini in the 95th centile, 99th centile, then the patient might need might kena bagi antihypertensive medication. The thing is it hypertensive due to renal condition or is it due to the pre-renal? So pre-renal maybe because of the fluids overload. Kalau ada evidence of fluid overload, then you want to give diuretics or furosemide. If there is no sign of fluids overload, then you need to try with possible amlodipine or nifedipine, calcium channel blocker, because it's mainly renal cause for the high blood pressure. So those are the thing that you need to look for. So given the evidence of from the history, and also from examination point of view, there's no sign of fever. Then you probably want to rule out. That's probably ruling out UTI lah. Okay. There is no sign of oedema, so unlikely to be nephrotic syndrome. There is no skin rash. There is no bruising. There is no joint problem. There is no abdominal sign or abdominal pain. Then probably you are ruling out HSP. You ruling out SLEs and so on. So you kind of like coming down to working diagnosis of possible infectious glomerular nephritis, isn't it? Okay, so what investigation you would like to do?
So for investigation, I would like to do urine analysis and also urine culture and sensitivity. Hello?
Okay. So one of the investigation you want to do, you want to do urine culture. You want to send for urine UFM and also urine culture again.
Yes.
Okay, because you want to rule out UTI. Okay. What other investigation you want to do? What else?
Because I suspect this patient had glomerular nephritis, I would like to do ASOT. So if it is more than 200, so it is evidence of septic infection.
Okay. All right. What else? So
And then
ASOT. Okay.
renal function test to look at the blood urea, electrolyte, and serum creatinine.
Okay. So renal profile or electrolytes. Okay. Okay.
And
what else?
And then to look at the complement level.
Okay.
Usually in acute glomerular nephritis, CT is low at the onset of the symptoms.
Okay, so you got reduced C3 if this is glomerular nephritis. Okay, so what happened to C4? Is it normal or is it going to be raised?
Maybe it is normal.
Okay, fine. So what is the difference with if you suspect nephrotic syndrome? So what would be the difference between nephrotic and nephritic in terms of C3, C4?
If nephrotic syndrome, I'm not sure about that.
I
I
think
think both are good.
What you guys think? We are we are democracy. Our country adopt democracy system, so you can always argue between yourself. So if you say both are low, both are normal, and then we can make a vote lah. Siapa setuju dengan siapa?
I think in nephrotic syndrome, C3 and C4 would be normal because there is no complement activation in nephrotic syndrome.
Okay.
Maybe
Anyone else?
Anyone else? Maybe it depends. In nephrotic can be low and it can be normal because based on the etiology of the nephrotic syndrome itself. So if it is because of the autoimmune like SLE, so the C3 and C4 level might be low. But if it is something else, so it might be normal.
So let's go back to what is the what C3 C4 levels in nephrotic? So you're going to say it is normal in nephrotic syndrome. Hello?
Doctor, can you repeat the question once again?
So I just want to know what is the C3? What do you expect the levels of C3 and C4 in nephrotic syndrome? So in nephritis, you kita agree that C3 is low, C4 usually normal, and what will be the C3 C4 levels in the nephrotic syndrome?
Both are normal, doctor?
Okay.
Both normal, in normal level.
Okay. So you don't really expect. So in nephrotic syndrome, you don't really expect changes to the C3 C4, isn't it? Betul?
Yes, doctor.
So you don't really expect changes to the C3 C4 in nephrotic syndrome, but in some cases, some of both of them can be low as well. In some cases, so but typical nephrotic syndrome, you don't really expect C3 C4. You don't really expect any changes to the C3 C4 complement levels. Okay, but in some cases, C3 C4 can be can be low as well. Okay, so but typically nephrotic, normally there's no change to the C3 C4. Okay, that's fine. Okay, so you want to do ASOT, you want to do urine UFAM and also urine culture, you want to do complements. So what else you say? You also want to do you guys mentioned that you want to do renal profile as well, isn't it?
Yes.
Okay, so what other tests you want to do?
Throat swab or skin swab, if the patient had before, throat swab.
So if somebody has UTI symptom, you want to do throat swab. If somebody got a kind of like skin lesion, then you want to swab the skin as well, because it could be that that could be the culprit ataupun the precursor that lead to glomerular nephritis. Okay, so you're talking about throat swab. What other tests you want to do? So what else? What other investigation you want to do?
Other investigation, full blood count.
Okay, you want to do full blood count? Why?
Because usually patient had hematuria, so maybe anemia.
Okay, so if you suspect some sort of massive bleeding, massive hematuria, then you basically want to rule out any anemia. Okay, what else in the full blood count that you are looking for?
Leukocytosis to rule out any
Okay,
infection.
so infection. Okay, what else?
Thrombocytopenia to
Okay,
rule out any
thrombocytopenia.
bleeding.
Okay, so you're talking about normal or low platelet lah. So kalau low platelet, it could be ITP. Kalau normal platelet, then you need to think about other causes lah, hemophilia and so on. Okay, so is it all you want to do, or you want something else? Some other test that you still want to do?
Should we order?
Excuse me, doctor.
Mm-hmm.
For FBC, should we look for hemoglobin level? Because the patient will have anemia.
Yes. Yes, we talk about HB level just now.
What about
Sorry, tak dengar apa?
sorry there. Coagulation profile to rule out any coagulopathy.
Okay, so if you suspect hemophilia or kind of coagulopathy, then clotting question screening is useful. So kalau dia normal, then that's normal. If it's abnormal, then you want to do further investigation to rule out maybe kalau macam ada clotting factors yang deficient, then you suspect, you will expect the coagulation screening will be abnormal as well, isn't it? Okay. So anything else you want to do?
Should we send for inflammatory markers?
Okay. What kind of inflammatory marker that you want to send?
So for daily, we can order CRP.
Okay. So how significant is CRP in this case?
So in this case, basically, it's not really give any helpful information.
CRP can be useful if you suspect UTI or if you suspect any infection, but most of the time, if this patient in this case, because the child is apraxia anyway, and then most of the time, if you suspect glomerular nephritis, the CRP is not really useful. Obviously, if the CRPs come back very high, like 10 ke 12 ke, then that's significant. If the CRPs only come back like 0.6 or 0.7, then it's not going to be useful at all, because it's probably just a sign of inflammation rather than infection. Okay, so what other tests you want to do?
Imaging, renal ultrasound.
So you can do a renal ultrasound. Looking for what?
Looking for evidence of pyelonephritis infection, and there's a fluid accumulation.
Okay, so if you're thinking about pyelonephritis or cystitis, then you expect a bit of inflammatory. Kalau macam pyelonephritis, you will see echo density when you do the scan. Maknanya it looks like swollen kidneys. The renal parenchyma is slightly swollen with brightness when you do the ultrasound scan. If there is any cystitis, when you do the scan of the bladder, you can see the lining of the bladder slightly thick. So those appearance on the ultrasound scan that is very suggestive of cystitis. If you're talking about kidney stone or bladder stones, many kidney stones, sometimes you can see the dilated ureter on the ultrasound scan. Obviously, if you looking for structural anomalies like hydronephrosis or PUG obstruction or duplex kidney or persistent kidney, then you can use renal ultrasound is very useful to detect that. Some of you probably want to do abdominal X-rays. Abdominal X-ray is probably not really useful if you suspect any kidney stone. X-ray of the abdomen is not that useful normally, because normally the X-ray can't detect the stone. Okay. Any other investigation you want to do? What if you suspect autoimmune or vasculitis disease? What test you want to send?
Double stranded DNA.
Okay, before that?
Before that.
AA.
So normally you send ANA, or you can send ESR with ANA, because autoimmune screening you normally send for ESR, which is non-specific marker, and then if the ANA is positive, then the lab will ask you to send another sample for anti-double strand DNA. Cool. So you can have most of the SLE will have positive ANA. If ANA positive, then you send for anti-double strand DNA. Normally, it's going to be positive. That is suggestive of SLE. However, ANA negative does not mean that it is not vasculitis. So some other vasculitis syndrome, polysystemic vasculitis, or other type of vasculitis can have negative ANA screening anyway. But for specific for SLE, SLE normally has positive ANA and positive anti-double strand antibodies. Okay. All right. So if you suspect nephrotic syndrome, obviously you will send for LFTs as well to look for the albumin levels. So what is the definition of nephrotic syndrome?
Hello, can I try?
Yeah.
All right, so in nephrotic syndrome, there's proteinuria with 1 gram per meter square per day, or hypoalbuminemia, less than 25 grams per liter, with edema and also hyperlipidemia.
Okay. Okay. So a couple of years ago, one of the students asked me, "Doctor, can you have nephrotic syndrome with normal albumin levels?" Is it possible to have nephrotic syndrome with normal albumin?
No.
Not confident with your answer. Is it yes or no?
No.
No. No what?
No,
I think no.
You think no?
There is another hepatitis, but I don't know if it's just the albumin.
Siapa yang bagi definition tadi? Sorry, is it Farhana bagi definition?
Farhana.
Yeah. So she says the definition of nephrotic syndrome is edema, proteinuria, hypoalbuminemia, and also hyperlipidemia. Okay, or hypercholesterolemia. Okay. So these are the 4 criteria that's been written in your PITS protocol. Okay. If you go to other countries like the US, the UK, and Australia, they only use 3 criteria, which is edema, proteinuria, and also hypoalbuminemia. You need to have these 3 to diagnose nephrotic syndrome. Okay, you cannot have nephrotic syndrome with normal albumin. You need to have low albumin to diagnose nephrotic syndrome, unless you have albumin. You have nephrotic syndrome, but you are in remission. Okay, so if you are in remission, then you will expect the albumin will be normal. But in remission, you have normal albumin. You also will have normal urine, which will be no protein, or if you go to PITS protocol, the remission is defined as 3 successive days with either trace or nil proteinuria, isn't it? No protein in the urine. That's how you are in remissions. But if you have edema, you have proteinuria, and then your protein is normal, then that's not nephrotic syndrome. It must be something else. Okay. Or it could be a liver problem, or it could be cardiac problems because of that. But you cannot diagnose. You cannot put somebody labeled as nephrotic syndrome with normal protein, with normal albumin levels. Okay, fine. So that's the list of investigation you want to do. So now I'm going to show you that's the investigation results from this case. Okay, so the HB is 11.7, which is not too bad for the age. White cell is 8.7, which is normal range, so there's no sign of infection there. Platelets is 372, which is normal, not thrombocytopenic. The renal function, renal profile shows raised urea and also raised creatinines. The LFTs, looking at the albumin, which is normal, 41. And then there's urine dipstick. So urine dipstick there, 4+ of blood, 2+ of protein, 1+ of leukocyte, and also nil of nitrate. And microscopy showing red cells and also red cell cast. So Africa, how do you summarize? How do you conclude this investigation?
Sorry, doctor.
So looking at this investigation results, okay, what is your conclusion?
So my conclusion from these investigation results, so from the microscopy, I can conclude that it is glomerular bleeding, glomerular hematuria.
Okay, why?
Because presence of the red blood cells and also red cell cast.
Okay, so the red cell cast is very suggestive of renal involvement or glomerular involvement, isn't it? Okay.
Yeah.
Okay. If you see a red blood cells, but there is no red cell cast, what could it be?
Sure, doctor.
Nephritic syndrome.
Nephritic syndrome. As your colleague mentioned just now, if you got red cell cast, it's very suggestive of nephritis. Okay, if there is no red cell cast, you still want to say this is nephritic syndrome. Faham tak? Faham tak soalan tu macam ni? Okay, so the important information here is the red cell cast. The presence of red cell cast in the microscopy is very suggestive that this is glomeruli ataupun vasculitis or nephritis involvement that cause the hematuria. If there is no red cell cast, then you need to think about something else. It means that the bleed probably coming from the renal tract, but it is not coming from the from the nephron, from the glomerular vessels. It's probably something like probably bleeding in the urethra, bleeding in the urethra, bleeding around the bladder, or it could be the period and so on. So those are the difference between having red cells in the urine and also having the red cell cast in the urine. Okay, so those are the difference. So if you got red cell cast, you can see in the urine, then it's very likely that this is due to the nephritis or vasculitis syndrome. If there's no red cell cast, then it's likely that the bleeding is not coming from the kidney itself. It's really coming after the kidney. It could be from the urethra, it could be from the bladder and so on. Okay, understand that?
Yes.
Okay. So renal calculi also can cause bleeding, but normally if you got renal calculi, if you do the microscopy, normally you don't see the red cell cast.
So doctor, red cell cast is exclusively for
glomerular pathology. Okay, and then you're talking about throat swab, ASOT, ESR, ANA, ultrasound scan, and also abdominal X-rays. Okay, so if I give you a scenario that when the ASOT come back normal, okay, ASOT come back normal, so is it then not post-streptococcal pulmonary nephritis? let's say ASOT there like 50. So is it going to be a post-strep infection, or is it going to be nephritis to something else?
We still cannot rule out the possibility, even the as negative.
Okay, so, and then what else you want to do?
anti-DNA.
Let's say the ANA is negative as well. So ANA is negative, ASOT normal. So what is the cause of glomerulonephritis?
The drugs.
Well, if you say it's a drug that causes blood in the urine, then it's not nephritis then. Betul tak?
IgA nephropathy.
Okay, IgA nephropathy. Okay. So, what is the difference? If you do the urine dipstick, what is the difference between urine glomerulonephritis and also IgA nephropathy?
The red cell cast.
So normally it will involve the red cell cast. Because if you're talking about nephrotic syndrome, normally nephrotic syndrome don't have red cell cast. IgA nephropathy, some says there will be red cell cast, some says there won't be red cell cast. So I'm not so sure which one is which in IgA nephropathy. It's going to be slightly difficult in terms of diagnosing IgA nephropathy, because IgA nephropathy can be diagnosed by doing the renal biopsy anyway. So what I want to say is, if ANA is negative, ASOT is not raised, what you need to do is you need to repeat again the ASOT after 2 weeks, because sometimes when you do the ASOT too early, the levels of ASOT titer probably not raised yet. So after 2 weeks, if this is a streptococcal infection that caused the glomerulonephritis, then normally you will see the raise of ASOT after 2 weeks. Okay. However, if there is no raise of ASOT after 2 weeks, and then we know the ANA is negative, if the throat swab come back positive for the streptococcal infection, then you can put them as a post-streptococcal infection because the throat swab is positive. If the throat swab also negative, but you have the history of URTI symptom beforehand, then you can put down as post-streptococcal infection glomerulonephritis, because sometimes about 20% of post-strep glomerulonephritis has no ASOT raise at all. So about 20% of them. So it's still possible to have post-strep infection AGN despite ASOT negative. Okay. Where's that?
So how long the ASOT will remain raised?
So normally people the study says the ASOT raise should be on a peak after 4 weeks of infection, and then it starts to come down and stays in the system down to like 8 weeks after the infection. So it will come up to about the peak is about 4 weeks. Then it's come down slowly. It takes another 4 weeks to disappear. So all in all, the range is about 8 weeks. The titer, raise ASOT titer. Okay, so we go a bit more about the diagnosis. So this patient is likely to have post-strep AGN, mainly because of the history of URTI symptom beforehand, and then sometimes PSGN tend to associate with oliguria, which is reduced urine output. Typically, most of them don't really have much difference in terms of their urine output anyway. So, but it's very important that if you suspect PSGN, you always do the strict input-output chart for a patient, just making sure that the child is not have fluid retention. Mild renal failure on the renal profile is quite common. but normally it's not really very significant in PSGN. The red cell cast is very indicative for renal involvement, as I mentioned before. Remember that when you see the red colored urine, you want to make sure where is this blood coming from. Is it from the is it really from the renal tract, or is it from the vagina for girls, or is it from the rectum in children's? Because sometimes constipation also can cause anal fissure or anal tear, and that can cause bleed as well. So you want to be very sure where is this blood coming from. And sometimes you need to think about physical abuse or sexual abuse as well. So that's very important. Your colleague mentioned about beetroots also can cause red urine as well. So sometimes medication like aspirins, cyclophosphomides, sometimes vitamin B complex also can cause dark brown colored urine as well. Hemoglobinuria, where you got hemolysis of your red cells, and the red cell hemolysis, the product of the red cells, hemoglobin especially can go into your urine and become hemoglobinuria and give the color of redness. So we thought it could be blood in the urine, but when you do the microscopy, because the red cells already hemolyzed, it's already broken down, so you don't see the red cells. You only see the redness, but it's not the red cell that causes the redness. It's the hemoglobin that causes the redness. So normally when you do microscopy in the hemoglobinuria, there's no red cells. It's just the redness of the urine due to hemoglobin color. Okay, this is the, I would say, differential diagnosis for hematuria. So UTI is the top of the list. Nephritis, which is post-trap AGN, HSP, IgA nephropathy, and some of the nephrotic syndrome also can come with hematuria as well. Calculi also can cause, it's not that common in children, but sometimes if you got hypercalcinuria or hypercalcinemia also can cause renal calculi as well. Some bacteria also can be associated with renal stones. So I don't know whether you know any bacteria that can cause renal stones that you know of. Anyone?
Okay.
Proteus.
Okay, so Proteus is most common bacteria that is associated with renal calculi. Okay, trauma is possible. Then you're talking about hematological causes like HUS or hemophilia, anatomical causes like polycystic kidney disease, hydronephrosis, tumors. So Williams tumor, which is nephroblastoma, is very common in children a bit less than 5 years old. The peak incidence of Williams tumor in children is 3 years old. Drugs, as I mentioned before, factitious illness, and also recurrent benign hematuria. Basically, we come to this diagnosis, recurrent benign hematuria. If we do everything else and it all come back normal, then this patient will still have recurrent hematuria. Then you put these levels down once you've done everything else, which all came back negative. Factitious illness is where you got psychiatric or psychological mental health with either patient or parents. I don't know whether you heard a term called Munchausen syndrome by proxy, where let's say in this case, parents got mental illness. Normally, parents will want to seek attention from something else. So what they do is they ask the kid to wee in a jar, and then they probably put darah ayam ke darah kambing ke darah apa-apa lah in the urines, and then brought the urine to the hospital to say to doctors that my child got hematuria. Okay, the way that you know whether this is fabricated illness or not is once you remove the parents from the child's care, the child is totally normal, and the child always been normal. Okay, so maknanya kalau budak tu tak duduk dengan parents dia, the child never had any complaint of hematuria. As soon as the child went back to parents' care, the child will have hematuria. So those are the factitious in it. So the parents or somebody will fabricate the evidence so that they can attract attention. Okay. And then we're going to be off treatment. So in post AGN, you normally treat them with penicillin for 10 days. Mainly you want to eradicate streptococcal infection. Okay, you don't treat glomerulitis with antibiotics. Okay, because glomerulitis is a condition that has good prognosis. It normally settles by itself. However, if there is any complication like hypertension, then this patient needs anti-hypertensive medication. But apart from that, it's a good prognosis. If the child has fluid overload, then you want to give furosemide if there is any sign to suggest hypertension. But usually you treat the child fluids intake from between 1 to 1.5 liter per day, and then you advise for low salt diet or no salt at all. If there is no sign of fluid overload or no sign of edema, then you can, and the patient still have hypertension, then you can try them with calcium channel blocker, either nifedipine or amlodipine. And obviously, if there is any sign suggestive of renal deterioration or very severe kidney injury, then you can do the hemodialysis for the patient. Normally, most of them are quite mild, not really any much intervention. So you can follow them up in clinics with a regular BP checkup and also the daily urine dipstick to look for a sign of blood in the urine. And some of them will progress into a nephrotic syndrome, and some of them can progress into the renal failure as well. But overall, post-strep AGN has had good prognosis. The gross hematuria tend to disappear within a couple of months. The microscopic hematuria takes some time to disappear. Some of them will disappear after 1 year. Some of them takes about up to 2 years to disappear. But majority of them resolve within 1 year after presentation. In children, when you're talking about hematuria, the three things that you look for is UTI, HSP, and also post-strep AGN. Okay, if the child is quite young, like 2 to 3 years old, with painless hematuria, with abdominal mass, then you need to think about Williams tumor. Okay, any question?
Doctor, I want to ask for this patient because the physical examination reveals that the child has hypertension. Do we also screen for the involvement of the eyes, like fundoscopy, as a baseline parameters?
Okay, yeah. You can do that as well, because sometimes you don't know how long this patient has been hypertensive, isn't it? So you probably want to refer to the ophthalmology just for the sake of screening to make sure that there is no sign of hypertensive retinopathy, and that's why if the child, if you think that you don't want to refer now, you probably want to manage the BP first, the high blood pressure first. Then if the hypertension has not been well controlled for about 1 to 2 months, then you probably want to refer to ophthalmology for eye assessment, just making sure that the child has not developed hypertensive retinopathy. Okay. The other thing is there is a comorbid of constipation. So constipation also can cause UTI as well. Okay, because sometimes you can have a full rectum. This full rectum blocking the urine outflow, especially the urethra, especially in girls. So it end up with the child have been having urinary retention multiple times per day because of the constipation. So making sure that in your history you want to ask about how is the child's bowel movement. Is it once a day? Is it once every 2 days? So, and then you want to ask the Bristol chart as well, you know, what in terms of consistency of the stools, because constipation is also is a known associated factors to UTI as well.
Okay, Doctor. Another question I just want to ask in this case, Patient have already have ATI and 4 years old. Is there any concern that we have to dig more about that? And is it
Yeah, I wouldn't say one UTI at the age of 4 with no complication. Looking at the history, it looks like it's a straightforward, simple UTI. It's not a complicated UTI. If that is the case, then it's probably not significant at all. Okay, unless if the child got ESBL, okay, ataupun multiple recurrent UTIs, then you start to be worried that it is something not right with the child, possibly in terms of dia punya structural anomalies and so on, right? But you want to make sure that if the child coming with recurrent UTI, you want to make sure that is it true UTI? So because you want to know the clinical definition of UTI is you have the symptom of UTI plus an evidence of bacterial growth in the urine. Then you consider that is recurrent UTI. Because most of the time that when you see a patient with recurrent UTI, if you go back to the history, nampak macam symptom of UTI. Tapi when you send the urine test, it's all come back no growth, it's all come back mixed growth and so on. So there's no confirmed UTI. The confirmed UTI is symptom of UTI plus evidence of growth in the urine culture. Those are the way that you consider a confirmed UTI. Kalau tak ada confirm bacteria in the urine, then you can say that it is just a possible UTI. It's not a confirmed UTI.
Okay, thank you, Doctor.
Okay, so it's 4 o'clock now. So it's been 1.5 hours. We need to go to the second case. Okay, it looks like this session also dragging to almost 3 hours, I think. Okay, so we have another one session. Okay, actually, one case. I've been doing three sessions so far. 2 sessions yesterday. It's also dragging to 3 hours as well. This morning also session dragging to 3 hours as well. I'm hoping that this one is not dragging to 3 hours. So yeah, if you can do before 3 hours, then you are the first one to break the record and not going for 3 hours per session. Okay, so who's presenting this one? Dahlia. Okay.
Yeah.
Okay. Carry on.
Okay, so this is my case. So I actually already dissect the case. So let us dissect together. So the chief complaint for this patient is 18-month-old boy that presented with history of unable to walk at the age of 18 months. So it's given that the birth history was born at 41 weeks gestation following an uneventful pregnancy, and there was a meconium staining of the amniotic fluid, but he cried immediately at birth and don't need any resuscitation. Okay, so for this, is it okay if I just talking? If you want to interrupt?
Yep. Yep.
Want to
Carry
reach
on.
the time.
Okay.
So for the birth history, from what I can comment, the baby was delivered post-date, but it was not post-term, and it was uneventful as even though it was said that there was meconium staining, but it resulted with no any signs of respiratory distress, and the patient given gas score might be normal and there's not required any resuscitation. So birth asphyxia or meconium aspiration syndrome is likely to occur. Okay, for medical history, he had he had cough and colds and previous history of chickenpox 6 months ago, which is at the age of 12 months, about 1 year. So what I want to inquire more about this is how about the infection itself? Is it how about the duration, and is it complicated with another illness such as is it involving other system like encephalitis? So I want to inquire more about this. And then developmental history. So from the history, actually we can see that the patient already presented with delay in the gross motor development. So here I already stated that For rollover, he actually achieved at the normal milestone, but since sit up without support, usually we expect the patient can achieve it by 9 months, but in this patient it delays to 10 months. For crawling, he started to crawl at 13 months, which usually normal children at 12 months old. And there is a problem when he start to use his lower limb, which is when he start to walk, like bear walking and also put to stand. Usually, normally, children can achieve at 12 months old for bear walk and pull to stand at 9 months old. But he already delayed until 17 months old. And currently, still the patient cannot walk independently. And from history, he still have to hold on to wheelchair while walking. So I think it's said about the cruising. So currently, patient still cruising on while walking. So this is the delay that I can notice. You can add more if you have another idea. So for fine motor, normal, at 18 months, he can scribble and he can use the fine motor will raise no problem. Also, no problem in his social and speech development. He use a lot of symbol appropriately, can understand simple instruction, he can feed himself, and also can play with toys tadi. And then based on his parents, there was no concern regarding the visual and also hearing. Okay, so this is what I just said previously. So for developmental history, what I want to highlight is that first we know that the patient does not have any global developmental delay, which we know that when there is involvement of two developmental domains, but only gross motor affected in this patient. And then other is we have to suspect more on any motor delayed disease such as in cerebral palsy. But however, in this patient, most likely to be is spastic diplegia because the involvement is more about the lower limb and muscular dystrophy. Okay, I'll tell you more about this, but also because of there is a signs of weakness of the proximal muscle and also normal for other developmental. We can also still consider Down syndrome. Maybe it does not present the in full features, maybe type of mosaicism, but usually also is usually early recognition of the syndrome itself. And what I want to highlight more about this history, I cannot find any point suggesting that it is a developmental regression or just development apa nama? Yang developmental progression. So I cannot find any. Is the patient have lost any skill that he already achieved, which means he has developmental regression. So next. Okay. Next, social history. So for social history, also there was no much problem highlighted. She attended nursery and described like a normal boy, but there is a concern that she still cannot walk. And his mother and father are at least 40s. She's like more on towards the advanced age of maternal and paternal, and they are hoping to have another child. So what I want to highlight the issue that maybe given here is first I want to inquire more about the family pedigree of this patient. So is Johan have another sibling with any history of developmental delay? And also I want to know the family pedigree, how many girls and boys if in muscular dystrophy such as it is X-linked disorder, so usually the boys will be affected. Okay, and then for the marriage, I want to know, is it consanguinity marriage between his father and mother? Because there is a syndrome, association with inheritance, and also because they are hoping to have another child, if we suspect of this is genetic disorder, we have to consider genetic counseling for these parents. So, and also risk of the pregnancy in maternal and paternal advanced age. So for family history, history said that there is no family history of delayed working. So I think there was not any apparent underlying risk factor so far. Okay, so can I proceed, Doctor?
Yeah, you can. Definitely.
Because patients are presented with developmental delay, so the approach is that we have to get a very thorough antenatal history, and so I start off what I would inquire in history by the birth history itself, because you want to know at which level that there is problems in this patient. So for birth history, I want to ask more. During antenatal history, there is any history of congenital infection such as starch, any prenatal diagnosis like any brain malformation, Down syndrome in screening such as, and then any early infection during another bullet, which is perinatal history. So during perinatal history, intrapaternity, is there early infection or also neonatal jaundice and birth asphyxia? And postnatally, is there any history of encephalitis and also meningitis? And then after the birth, is there any does he require any NICU admission? And for the mother itself during the pregnancy, is she any on medication or drug? For what I mean from drug histories here is maybe we should ask the mother if she's taking any illicit drug like tobacco, cocaine, and also alcohol itself, which can cause some defects to the brain development to the babies. Okay, the next one is developmental history. So because the parents say that they have no concern regarding the visual and hearing, so but we have to ask more. Is there any proper visual and hearing assessment done to this patient to give a more clearer explanation about that? And then, sorry, doctor.
No, carry on. Carry on.
Is there any developmental regression? Just what like I explained before. And also I want to know the growth parameter of this patient. So we have to ask the parents about the chart, the growth chart of this child. Is there any abnormalities like, for the length, weight, and also head circumference? Head circumference. Okay. The next one, medical history. So are there medical issues in this patient? Because the syndromic disease, they can also accompanied by other effects like heart problem, GIT problem, pulmonary problem. So we have to ask more about that. And is there any problem with feeding for the nutritional history? And then the last one, the social history about the child well-being and support. Because neglect and abuse also can be one of the causes of developmental delay. So we should not underestimate that. So this is the further question about the history of presenting illness for my differential. So for cerebral palsy, we have to ask more about the abnormal posture, like diplegia. There may be adduction of the hip, flexion of the knee, and also plantar flexion, and also any rigidity. For muscular dystrophy, how about the gait? Is it waddling gait? Any Gower signs, clumsiness, stiffness, spine problem, and respiratory problem? For Down syndrome, so any facial dysmorphism, cardiac problem, GIT problem, and metabolic disorder, such as if you have growth problem, feeding, and GI problem, abdominal swelling, reduced effort tolerance. And lastly is systemic review, because we don't want to miss any problems in this patient, because like I just said before, the bacterial have the disease can also have associated with other involvement of the system. Okay. Diagnosis. So for my provisional diagnosis, so I think for this patient, I would like to suggest my provisional would be muscular dystrophies. The points for is because patient is male, so muscular dystrophy is X-linked recessive disorder. So male will present manifestation. Okay, and then there is the delay in gross motor, such as walking and standing. However, normal development other domains, and the onset usually in muscular dystrophy, we can start notice when the patient start to walk 2 to 3 months old.
Okay. Too early, yeah.
Bukan salah ni. 2 to 3 years old, sorry. Salah. 2 to 3 years old. Okay. So for points again, so far I cannot find any points again muscular dystrophies. And for differential, so cerebral palsy, the points for is because there is a delay in gross motor. However, the points again because we cannot appreciate any, there is no reported any abnormal posture or command crawl during the crawl phase, and the patient had normal vision because spastic diplegia patient usually can have strabismus. And then Down syndrome, also the points for it can have also delay in gross motor, but usually it is prenatal diagnosis, and there was no any abnormal facial features noted, and there is no other symptoms of another involvement of systemic illness involved also. So for metabolic disorder, it can be due to inborn metabolism or hypothyroidism. Also, it is can cause delay in development. However, for especially it can be rare because usually it's early recognition of the syndrome of the disease, and there's also other neurological symptoms that usually they can cause seizures, vomiting, and there was no any evidence of heart failure, reduced effort tolerance, and also there's no any vision problem like droop eyelid and ophthalmoplegia to suggest IEM. And the last one is neurodegenerative disorder. So point spot is because delay in gross motor, and it can be due to post-viral infection, but usually it's a chronic viral infection. And for points against, it's because I cannot see any points that suggest of developmental regression, and usually neurodegenerative disorder affect premature baby. From what I read. Okay, so others causes of developmental delay that we should think of is neurocutaneous disorders, spinal muscular atrophy, myasthenia gravis, and idiopathic causes such as autism.
Okay. I think that's quite comprehensive in terms of the way that you categorizing your differential diagnosis and what information you want to extract from parents to support your working and also your differential diagnosis, which is a good thing. Okay. I would like to bring all of you back to the history taking first. Okay, so your colleague mentioned antenatal history about infection, isn't it? So you're talking about touch screenings, you're talking about apa lagi? Touch screening. So you're talking about antenatal infection, which is mainly talking about touch screening lah. So toxoplasma, rubella, cytomegalovirus, and also herpes simplex. So it's very important to dig out from parents whether it's any antenatal infection during pregnancy. Okay. You also would like to know in terms of, is there any history of placenta insufficiency, for example, gestational diabetes or preeclampsia that sometimes can lead to poor brain growth sometimes. So those are in terms of antenatal history. The other question you want to ask is, I just want to add on further on your history was activities of the fetus. So reduced fetal movement is very important as well, suggestive of possible encephalopathy secondary to genetic conditions. And sometimes hyperactivities of the fetus also could lead to neurologic condition as well. So, but the thing is, parents probably don't really realize that the fetal activities if this is a first pregnancy. Normally they notice more the second pregnancy or subsequent pregnancy because they can compare. But before that, first babies probably they don't really realize activity of the baby. Okay. The other thing you want to know is the antenatal scan. So scan, was it normal? Was it abnormal? Was it any brain anomalies, or is it any any kind of abnormalities that the antenatal scan information that you can extract from parents. The other thing you also want to know is the lichor. Is it normal lichor? Is it polyhydramnios or is it oligohydramnios? Okay, color polyhydramnios means that the babies probably have swallowing problems. Okay, because your lichor is maintained fetal urinating and also fetal swallowing of the amniotic fluids. Okay, those are the way that they maintain. So kalau oligohydramnios, then you worry that the child probably having problem with the kidneys because the kidneys not weighing weighing to replace the amniotic fluids that have been swallowed. So those are the thing that you probably want to ask as well. So further question about LICOR as part of the antenatal history. I agree with you, but postnatal, that's not much into postnatal. Basically, you're talking about infection, jaundice. You're probably talking about any trauma, any accidents and anything like that. So those are the things that you can ask about. But from this case, I don't think that they are going to tell you about regression because they are talking about development from birth until about 18 months old. So they're not talking about regression at all. Kalau regression means that the child already achieved the walking stage and then suddenly not working at all. So those are the regression, but there's no element of regression at all in this case. The other thing is it's very important to know the mechanism standing at birth, and especially does the patient need any resuscitation. So this baby got very little mechanism standing and not needing any intervention at delivery. So if somebody got mechanism aspiration syndrome or developing persistent pulmonary hypertension of newborn, they will be more unwell. They normally will need to be admitted to NICU for intensive care management. But this boy does not need that. The question now is, does the chickenpox at 12 months old significant or not? Do our scientists is part of your group, eh?
Yes, doa.
Okay. So Dua, is it significant? The history of chickenpox at 12 months old, is it significant or not?
Significant. Sorry, I'm lagging a bit.
Okay.
History of
chickenpox at 12 months old. Is it significant in this case?
12 months. I think it is. Because by 12 months, the brain is still developing.
Okay.
So if he had a history of chickenpox and it was a severe infection, then it could affect his motor development.
So what kind of severe infection that you can think of?
I'm not sure. Apart from his chickenpox.
Okay. So anyone else can help Dua to answer the question? Aiman hilang lah, Aiman. Aiman ada lagi.
Yes. You mean other infections than chickenpox?
No, we're still talking about chickenpox. So how can chickenpox is significant in this case?
It can cause us chickenpox encephalitis, especially at 10 months old. I think the child hasn't got the vaccine for chickenpox yet.
Well, have you guys got chickenpox vaccine?
Oh no.
Yes, varicella encephalitis is quite it is a known entity. Okay, varicella encephalitis, or sometimes you can have varicella cerebellitis, which affecting your cerebella. If you got varicella cerebellitis, then you will have cerebellar signs, ataxia, and so on. If you got varicella encephalitis, means that your brain parenchyma probably inflamed because of the varicella infection. Then sometimes it can affect in your motor development. So it could be possible that this child had chickenpox at 12 months, and the chickenpox is quite severe, that probably lead to encephalitis then probably affecting the gross motor. The thing is, he had the chickenpox at 12 months old. However, it's already showing sign of developmental milestones, delayed developmental milestone, because he's only can sit alone, can sit up alone independently at the age of 10 months. Okay, sitting without support. At what age that you expect a child to sit without support? So sitting, there's two stages of sitting. Sitting without support with the curved back, and then the second stage is sitting without support with the straight back. So sitting without support with the curved back, from what age do you expect?
Curved back is 6 months with support.
Okay, so it's 6 months with the curved back, and then straight back.
9
So about 8-9 months old. Okay, so this child only start to set up alone at the age of 10 months. So it's already delayed at that time. Okay, so I don't think that the delayed development happened because of the chickenpox at 12 months old, because this child already shown the sign of delayed developmental gross motor development already at the age of 10 months. Okay, so those are the things. Okay, so I'm just going to show you the examination finding. Okay, nak kena minta apa, dah have to stop sharing the slide so that I can share your slide.
Doktor boleh je share terus.
Why? Okay, how do I share?
Doktor tekan je dekat presenting tu.
Okay, okay. Okay, can you guys see my slide?
Yes, doctor.
Okay, so basically, this boy has looks very well in himself. He's interacting with you as normal. He does not look dysmorphic. So basically, we just want to tell you that this child is not Down syndrome or anything else. The weight and height is on the 25th centile, which is okay. The head circumference 50th centile. Does this mean that this child has macrocephaly?
Usually we take the standard deviation, right?
Okay, so for 25th to 50th centile is only one centile difference here, so it's not a big difference. You start to worry if the child has the difference between head circumference dengan dia punya body weight and also dia punya height dia more than 2 centile, mana crossing 2 centile. So kalau lah tiba-tiba if the head circumference maybe up to 90th centile or 95th centile, then there's a big difference, more than 2 centiles difference. Then you start to worry that this child have microcephaly. If that is the case, then you worry about any brain specific lesion, hydrocephalus, and so on. So, but differences of 1 centile is not significant at all. So it's also mentioned that the cardiovascular, respiratory, and also abdominal also normal. The spine also normal. Joint also looks normal. There is no neurocutaneous lesions. There's no birthmarks. Cranial nerve examination was normal. Normal posture, normal tone, normal power, normal reflexes on the upper and lower limb. The child does not have any tremor. So neurological examination ini basically we want to tell you that this child is not CP. Because if you got CP, then you expect a hypertonia, you expect weakness, you expect hyperreflexia, you expect the posture will be like seasoning posture or abnormal posture, and normally some child with CP has tremor as well, could be attitoid tremor, and then this is a very important bit there when he is helped to stand. So he needs help to stand, holding to the side of the tables, and then he can take a few steps with both hands holding together. So when he mentioned that he needs help to stand, ataupun diperlukan he needs perlukan bantuan untuk berdiri. What does it mean?
The weakness is at the lower limb, at the proximal muscle.
Okay. Okay. So the weakness on the lower limb. That's what you mentioned. Okay.
Yeah.
So if you say the weakness is in the lower limb, so why neurological examination says that the normal this patient has normal posture, normal tone, normal power, and normal reflexes?
I think patient could be having weakness at the trunk area since he was unable to stand, but once he's standing, he was able to walk.
Macam mana?
Mungkin weakness dia tu dekat area trunk because he was not able to stand, but when he was standing, he was able to walk.
So basically, when we mention about need help to stand, for example, need help to stand means that if a child was squatting or sitting down, the child will need help to stand up. Do you guys understand? Do you guys understand what does that mean?
Maybe due to instability.
Okay.
So it's affected the cerebellar part of the brain. So
cerebellar does not really. Cerebellar tend to affect you if you are walking, but from sitting down to stand up, it does not really involve your cerebellar function. Just try to imagine that a child in a squatting position. However, when you ask the child to stand up, the child is not able to stand up without any help. What does that imply? Okay, proximal what?
Lower limb.
Proximal apa namanya? What does that call?
Proximal myopathy.
Yeah, it's proximal myopathy. Okay, the proximal myopathy, or the other term that you guys will remember is Gower signs. Gower sign is a sign of proximal myopathy. Okay, so this child, so with this examination findings, with the history with the history that you know, that this child has proximal myopathy. Okay. So now, what is the top list of your diagnosis then?
Muscular dystrophy.
So you're talking about Duchenne muscular dystrophy. So apart from the proximal myopathy that he has, what is the other significant information that supporting this is Duchenne muscular dystrophy?
Male?
Apa?
Did you mean in examination?
Yes. No. The history or the examination.
I think because the onset and also the patient is male.
Okay, so the most important information is this patient is a male patient. So it's a boy plus proximal myopathy. Then you need to rule out Duchenne muscular dystrophy first before anything else, until proven otherwise lah. Okay. So back to your list of your differential diagnosis. What investigation you would like to do?
Okay, so for investigation, I think the most important one for to rule out this differential is cerebral creatine kinase. Okay. Penat saya using.
Yeah, but you can view yours.
Right. Can you all see my slide now?
You can.
Okay, so this is examination. So for investigation, for the Duchenne muscular dystrophy, the most important investigation to say is serum creatine kinase, which is there will be elevated serum creatine kinase, usually about 10 to 20 times of the normal value, and also elevated transaminases. So we also have to send liver function test. But to out other pressure, I also send for full blood count. So basically this one because to rule out for complication, because in Duchenne muscular dystrophy, patient can have recurrent chest infection. And also thyroid function test, because one of my depression is metabolic congenital hyperthyroidism. So and then for imaging, I would send for MRI of the brain to rule out any cerebral malformation, such as ECP, and chest X-ray to see the first rule out any pneumonia, and also see the I don't know if you can see the diaphragm diaphragm weakness in muscular dystrophy in chest X-ray, because usually they will have diaphragm weakness, but I don't know if you can see it chest X-ray. And spine X-ray, because Duchenne muscular dystrophy can also affect the back, which is can have scoliosis, and echocardiography to see the function of the heart, because in Duchenne they can cause dilated cardiomyopathy.
Okay.
So for special test, because Duchenne is a genetic disorder of deletion of the chromosome 31, okay. And then cause reduce in the production of dystrophin. So we can send for PCR for dystrophin mutation and muscle biopsy. Okay, for others like other differential like IEM can send for respiratory chain enzyme, but I don't know if we have it, and also karyotyping.
Okay. 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 This is just investigation. So bedside glucose. So part of the metabolic conditions or inborn error of metabolism. Sometimes you're talking about mucopolysaccharides, MPS type 1, MPS type 2. But obviously in this case, the most important thing you want to do is you want to do TFTs, which is congenital hypothyroidism that can cause delayed developmental milestone. And CK is very, very important in this case because you're suspecting muscular dystrophy. Normally in Duchenne, you expect the CK would be like 10,000, 20,000, 30,000 because the child's muscles is constantly, persistently being destroyed, being breaking down, every day, every hours, every minute, every second. So that's why they have high CK levels. CK is part of your chemicals, part of your enzyme in your muscle fibers. So if your muscles, if thousands of your muscle fibers been breaking down, so your serum CK will be high. Okay, and sometimes it can also affect your smooth muscles as well, and affecting your liver function as well. Okay, so if you suspect a bit of CP, so in this case, if it affecting the lower limbs, then you suspect it could be the plegia CP. So if that is the case, then you want to do either MRI brain to look for any lesion in the brain, and chest X-ray. Sometimes you're looking at the function of the diaphragm. So kalau diaphragm they're not that functioning well, then you see the diaphragm is like a dome diaphragm. So it means that the diaphragm is not functioning that well, and plus you got a very narrow chest wall as well. If the diaphragm not functioning very well, in Duchenne, if you don't really manage them quite well with steroids, with physiotherapy, and then they can develop scoliosis as well. So you do X-ray to assess the spine. Okay, and also delayed walking, you also want to rule out, we call it congenital dislocation of the hips. Okay, because sometimes you don't notice that the hips are dislocated, and was the reason why the child is not walking properly or cannot walk because of the hips dislocation. So you always want to assess the hips, making sure the hips is not dislocated. And obviously this special test, with normally to diagnose Duchenne, you just need CK and then you need muscle biopsy. You don't really need PCR and also karyotyping to diagnose Duchenne muscular dystrophy. Karyotyping is only looking at your numbers of chromosomes plus whether you are boys or girls. That's all. So if you got 46 XY or XX, then you are normal. If you got less than 46 or more than 46, then you are abnormal. So karyotyping is only if you suspect trisomies or Turner syndrome or chromosomal disorders. But karyotyping in Duchenne will be normal. The one that is abnormal will be the next sequence generation or genetic microarrays, which is looking at the allele and gene of every single chromosomes in your cells. And obviously, if you suspect Duchenne, then you can do a PCR just looking at the dystrophin mutations, gene that look after your dystrophin. So it's still part of the next sequence generations genetic studies anyway. So those are the way that you investigate this patient. But obviously, if you suspect CP, then you do MRI brain. If you suspect hips problems, then you do a pelvic examination X-rays. If you suspect metabolic, you do IEM screening. You do the TFTs, and then that's it. Unless if you suspect more than that, then you need to do further investigation ataupun further testing.
So doctor, CK is already enough to diagnose
So
Duchenne?
yeah, CK, I would say, if it's very high, it's going to be very suggestive of Duchenne. However, you need to do muscle biopsy, okay? Because I wouldn't say CK only is enough to diagnose Duchenne. You still need muscle biopsy, because sometimes you can have a condition called juvenile dermatomyositis that have high CK, but you need a muscle biopsy to rule out other causes. So juvenile dermatomyositis still require muscle biopsy to diagnose juvenile myositis. Okay, but the blood test, if you do CK on the juvenile dermatomyositis, the CK will be high, tapi it won't be as high as Duchenne. Duchenne probably up to 10,000. Kalau JDM ni, juvenile dermatomyositis, probably about less than 10,000, I would say, because in JDM the muscle is inflamed and swollen, but it's not destroyed. It's not breaking down like Duchenne. Duchenne tend to break down the muscles. JDM tend to be inflamed and swollen muscles. Some of them might be destroyed as well. Some of them might be breaking down, but the process takes a long time. And JDM tend to be autoimmune, tend to be acquired rather than congenital.
Okay, good.
Okay, I'm going to share a bit more about my slide. Anything, just ask me. Can ask me. Can interrupt and ask question. Okay.
Doctor, still we put any syndromic like Down syndrome as our differential?
You can you can put in genetic causes for this as well, because if the child, as you mentioned about mosaicism of Down syndrome, sometimes mosaicism you got a very mild dysmorphic features. So sometimes you diagnose Down syndrome for the mosaicism is late, mana lepas mungkin 3-4 tahun, 2-3 tahun baru diagnose Down syndrome, because the features is not as obvious as as yang biasa-biasa. So sometimes you miss Down syndrome because of the mosaicism type.
And this karyotyping will be helpful for the mosaicism.
Yeah, it will be helpful. It will be helpful because at least it will give you kind of like genetic composition of karyotyping. However, you might not seeing a proper trisomy 21 in mosaicism. So sometimes it's difficult to do a karyotyping, but normally they have a special way to diagnose to see the mosaicism in that situation.
Alright.
Okay, so I'm just going to share my slide a bit here. Can you guys see or?
Yes.
So the most important investigation in this case is the CK, and then if it's high, then you can proceed with muscle biopsy. The thing is, there's not much you can do about Duchenne. If this Duchenne, you only can start with you can start treatment with pregnant children early to slowing down the progressive nature of Duchenne, because Duchenne is basically you got your muscles destruction day in and day out. Every time your muscle is being destroyed, so you use steroid try to slow down the processes of the muscle weakness, and then the mainstay of treatment for Duchenne is basically physiotherapy. So more physiotherapy, aggressive physiotherapy is going to be helpful in this case. In this case, and sorry, I got a bit of distraction there. The mainstay of treatment for Duchenne is physiotherapy, and there is a new medication called Atoluren, but obviously Atoluren is not readily available in Malaysia. I don't know whether HKL or I think in 2016 HKL and also got the supply of Atoluren from the company outside as a center for trialing this medication for Duchenne. So I think if the parents would like to try this medication, you can refer to HKL or to get this medication. It's a medication called Atoluren. It's an exon skipping medication. Means that it's improved the muscles strength and improve the muscles muscle fibers stabilities, but it's still on trial. So I've not seen I've not used Atoluren to any patient yet, because in the UIE Medical Center we don't have any patient with Duchenne muscular dystrophy. So that's why I don't have any Duchenne patient in my clinics. I think HTA has some
medication.
Sorry,
what is the name of medication?
It's Atoluren, Ataluren, Atoluren. So I think if you type Atoluren Malaysia, I think there's ada macam berita news about Atoluren trials in Malaysia. It's only in HKL or So kalau parents nak juga, you can refer to HKL or for trial. But the mainstay of treatment for Duchenne is basically physiotherapy. So if they got a good physiotherapy regime, and then they can survive up to 30s, 40s, rarely 40s lah, mainly 20s, middle of 20s. The reason why why they have early death is due to recurrent chest infection and also dilated cardiomyopathy. So they can have sudden death because of that. And then most of them will require non-invasive ventilation, home CPAP, because of the poor chest compliance. Okay, delayed walking is a common problem in children. The problem is we will always tell parents or doctors that if the child is not walking by 18 months old, you need to be worried. It means that you need to take action and investigate the reason why the child is not walking. About 90% of them not walking probably is a normal variance. It's probably normal late walker. 10% of them will have neurological conditions, and then 10% will have other areas of developmental delay as well. And only very little numbers that has muscular dystrophy. So not many actually turn out to be muscular dystrophy. So this is my differential diagnosis. If you suspect, then you need to think about CP and Duchenne. If it muscular, at the most of the hips, you might send a karyotyping as well. And if all come back normal, then you just wait and see that the child probably will walk without any problem after a while. Any question?
Doctor, if the patient is normal leg walker, but does the patient will also presented like with a goal sign, or goal sign is specific to muscular dystrophy?
Macam mana?
If normal leg walker, will they also present with the goal signs, or the goal sign already?
Not necessarily. So the Gawa sign is a pathognomonic for proximal myopathy. Okay, if somebody has proximal myopathy, then it is pathological. Okay, kalau patient yang normal leg walker ni, normally they don't have proximal myopathy. They just not be able to learn the skills to stand up and to walk yet. Okay, so proximal myopathy is a pathological, is a pathognomonic for a pathology. So leg walker normally don't have proximal myopathy. Proximal myopathy maknanya there ada something not right with the muscle lah, with the joint ke apa ke, and so on.
Okay, doctor, should we know there is another type of muscular dystrophy like Becker?
Well, I think you need to know Becker and Duchenne. Yang lain-lain tu macam apa, limb girdle, yang apa fascio fascio-humeral semua tu, those are very rare. You just need to know the Duchenne and Becker's. I think that's enough. You need to know the rare one, because at the end of the day, I don't think that you will see Becker anyway. If you're lucky enough, you will see Duchenne, but I don't think that you will see other type of muscular dystrophy.
Okay.
Okay. Any other question?
Actually, I want to ask about the genetic counseling. What is your opinion for these parents? They are how actually you can advise them with that?
So basically, you just tell parents that in genetic counseling, okay, you basically want to know who is the carrier. Okay, so when you refer a child, so when you refer a family that has a child with Duchenne muscular dystrophy, then what they normally do is they will test kalau dia adalah X-linked recessive punya condition. So in this case of Duchenne, then they will test the mom if mom carrying the genetic for Duchenne. Okay. If mom carrying the genetic for Duchenne, then you will tell the parents that if your subsequent pregnancy is a boy, there is highly there is there is a chance that your boy will develop 50-50 chance of developing Duchenne. Okay, if it's a girl, then that's fine. If it's a boy, then your boy will be 50-50 developing Duchenne. So those are the thing that you will tell parents. Whether the parent decided to abort the pregnancy, if they find out that the child is a boy, then akan ada discussion in terms of fatwa and so on. Okay, some fatwa says at certain ages, if you abort, then hukum dia harus. Some of them will say otherwise. So it's all about you as a perinatal team. You basically will tell parents what is the fatwa out there, and then the parents can choose which one they want to use if they want to abort the pregnancy or not. But you tell parents that your son will be 50-50 in term of developing Duchenne or not. If it is a boy, kalau girls, then it should be okay.
So doctor, is there any prenatal investigation if the following pregnancy is likely a boy? So is there any prenatal investigation to know that patient have likely to have Duchenne or not?
So normally what they can do is they can take the amniocentesis and they send for karyotyping, and also they can send for PCR PCR dystrophin gene. Okay. Kalau girls, then you don't need to worry. Cuma kalau girls maybe nak kena buat genetic testing lah for the future to see whether the child the girls is carrier or not. Kan? Right, any other question?
Doctor, I want to ask regarding the developmental delay. So is there any specific definition to say that this child has developmental delay, like 2 months down back to?
Tak ingat sangat. Need to speak louder.
Regarding the developmental delay, is there any specific definition to say the child has developmental delay?
Okay, sorry. So developmental delay. So you need to go back to your domain of developmental milestones. So you have the gross motor, the fine motor, the speech and language, and also your social skills. Okay. If you only one domain that is delayed, then you call it isolated delay. So in this case, you're talking about gross motor delay. So you're talking about isolated gross motor delay. Okay. If you have more than one, meaning 2, 3 or 4 domains involved, then you call it global developmental delay. Maknanya kalau in this case, kalau dia ada gross motor plus fine motor yang delay kan, then you call it global developmental delay. So 2 and more, and then you consider as a global developmental delay. In this case, it looks like the gross motor tu memang confirm delay lah. The fine motor, the child is able to use both hands using crayon and scribble on both hands, either hand kan. So what does that signify? It signifies that this child has not got any hand preference yet, isn't it? So if I ask you, hand preference start from what age?
18 months to 2 years.
Okay, so 18 months to 2 years. Okay, so despite this child is 18 months, so and it looks like the child has not developed hand preference yet, so I'm not too worried because you can live until about 2 years before the child showing any sign of hand preference. However, if the child develop hand preference before the age of 18 months, like 12 months old, 15 months old, then you need to think about possible CP, because if CP got hemiplegia, then the CP person tend to use one hand that is free, that is not affected. So sometimes the first presentation of CP is hand preference. So if a child develop hand preference before the age of 18 months, then you need to think about possible cerebral palsy. Okay.
thank you.
Right. Anything else? Any other question? It's 5 o'clock yet already. At least.
Late presentation.
Oh, sorry. Bising
Bising.
Apa?
Sekejap, dengar ke?
Okay. Okay.
If we found a patient at late presentation, maybe at 6 years old, maybe like that. If steroid is already, is steroid still efficient in this
Well,
for treatment?
they basically depend on how severe they are lah. Kalau umur 4 tahun dah wheelchair bound kan, poor lung compliance, and then you can still try with steroids, but the prognosis is probably not good at all lah. You're probably expecting the lifespan probably not great lah. Maybe probably you probably prolong the life to teens, probably not to 20s, not to 30s lah. So those are you can always start steroids to slowing down the progress of the Duchenne, but you tell parents that the prognosis is not good lah, because normally you start once you diagnose Duchenne, you start treatment early, you start the physios early, you do the aggressive chest physio. When I say aggressive chest physio ni, bukan yang masuk chest physio kuatkan kahak. You doing macam apa? Macam hydrotherapy session. Maknanya hydrotherapy session ni macam swimming kan. Swimming you got involved all 4 limbs, plus it's also good for your lung function as well. So those are the aggressive treatment, aggressive physiotherapy that you advise parents to do for their child. You go to the gym, go to the swimming pool and do a lot more swimming sessions, because that will improve a lot of their limb function and also their lung compliance and lung function as well. And then obviously they start on steroid to slowing down the breaking down of muscle fibers.
Okay. Okay, thank you there.
Okay. Any other question? So it's 2.5 hours. Oh dear. You guys doing very well.
Dia orang
Jangan tak gambar.
Tak gambar.
tak nak buka lampu.
Tak nak buka lampu. Aiman tak buka lampu dah confirm. Aiman tak buka lampu.
Siapa nak takkan tak gambar ni?
Siapa nak ambil gambar? Azfar tak pergi bubble ni.
Bolehlah screenshot lah, semua screenshot. Okay, 1, 2, 3. Dah.
Thank you so much, Doctor.
Right, thank you very much. Thank you for coming. Thank you for your participation. I'm sorry if this session is not ideal enough, but I think for the time being, this is what we can do at the moment. Obviously, we will do more session with you guys. So at the moment, we're just going to do PBL session with me, because I actually have a list of patients that parents agreed to be called for you guys doing the clocking and doing a long case presentation. Cumanya we got instruction from Prof Mazuki last week that student calling parents is not allowed yet because of the medical legals. So that's why I didn't release the list of patients for you guys to clock in. So as soon as Prof Mazuki says can do, then we will arrange name of parents and phone numbers for you to call. But at the moment we're just waiting for the Kuliah of Medicine to give us a green light. Until then Manik, if we're still doing this, then I'm just going to do the PBL session like this, problem-based learning session like this. So I'll give you cases yang lain-lain lah untuk buat discussion. Obviously it's not ideal because you are in your clinical years, you should be seeing patient, you should be clocking patient face to face, and I don't know how much this PKP, this COVID is going to affecting your quality of our students at the moment. Yeah, and the plus we still don't know how we're going to assess you in terms of exams, in terms of logbook, in terms of continuous assessment, because it's not easy. It's not easy. I don't know lah kalau korang nak buat granulation dekat rumah macam mana, cucuk sendiri kan. Jadi makpit for part time makpit, I don't know lah. So at the moment we still struggling in terms of, we still don't have a final way to assess you guys yet. In terms of logbook pun I don't know lah macam mana. So far I think we still need to discuss in terms of how what is the way to assess your procedure skills, your logbook. Yeah, I don't know. Maybe korang kena buat, I don't know, kena buat video sendiri ke, ataupun korang kena buat TikTok ke, buat poster and so on. So tak tahu lah. We just need to discuss again with Prof Marzuki in terms of how we're going to assess for the continuous assessment. Kalau macam ni, at least we have evidence that you are participating in the discussion, even though I don't see Aiman punya face, so I don't know lah. So tahu mungkin dia makan lemang dengan rendang kan.
Jadi kamera
apa?
Tadi
Kamera. Itu alasan itu mana?
Dia komputer desktop.
Aku pilih desktop. Okay, so fine. I think that's all. If there's no question, then we're going to adjourn our session with Tasbih Kifarah Rasulullah.
Thank you so much, Dr.
Okay, thank you very much. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr.
Bye.